trial. Dr. Gupta.
Good afternoon. I have to bring you back to mundane matters after Dr. Wohlmark's soaring talk. So I would like to thank the program committee of SABCS for the opportunity to present our work. On behalf of my colleagues from the Breast Cancer Working Group of Tata Memorial Centre, Mumbai, it is my distinct privilege to present to you the results of our study. We have no relevant disclosures. A long-standing question has been the benefit of addition of platinum in the adjuvant or neoadjuvant settings in triple-negative breast cancer. Some recent immune checkpoint inhibitor-based studies have already incorporated these agents as part of the chemotherapy backbone. Previous phase 2 studies have suggested an increase in pathological response with the addition of platinum in the neoadjuvant setting, but these studies were underpowered for survival. In particular, the GEPAR-62 and Brightness studies showed an increase in event-free survival with the addition of carboplatin, but the CALGB study did not. We conducted and report here for the first time a phase 3 randomized controlled trial powered for EFS to answer this question. Women with triple-negative breast cancer with clinical T stage 1 to 4, clinical nodal status 0 to 3, no evidence of metastatic disease, who were fit to receive anthracyclines, were randomized 1:1 to either receive or not receive weekly carboplatin as part of the chemotherapy, neoadjuvant chemotherapy regimen. They were stratified by menopausal status and clinical stage prior to randomization. The chemotherapy comprised of paclitaxel at 100 milligrams per meter square with or without carboplatin dosed to AUC2 once per week for 8 weeks, followed by 4 cycles of standard AC or EC chemotherapy. The patients underwent surgery after the last cycle of chemotherapy, followed by standard radiotherapy. The primary endpoint of our study was event-free survival, and it was powered to detect an absolute increase of 10% in this endpoint for a total sample size of 720. The key secondary endpoints were overall survival and the proportion of patients with pathological complete response. All patients underwent routine staging with either a CT scan and a bone scan or a PET CT scan prior to study inclusion, and capecitabine was not used after surgery. The study closed to accrual in January 2020 after full accrual. After excluding 3 patients with eligibility violations, the modified intention to treat population comprises of 717 patients whose outcome is being reported at a median follow-up of 67 months. The 2 arms were well balanced with respect to patient and tumor characteristics. About 70% of patients were younger than or equal to 50 years of age, and about 60% were premenopausal. This was a high-risk population of TNBC patients. About 60% had locally advanced breast cancer, 88% had clinical node-positive disease, and 77% had tumors that were larger than 5 centimeters. 90% of patients had invasive ductal carcinoma. In the modified intention to treat population, the addition of weekly carboplatin in the neoadjuvant regimen resulted in an absolute increase of PCR by 14.2% from 40.3% in the control arm to 54.5% in the platinum arm, which is statistically significant. When analyzed by age, the benefit of carboplatin is almost exclusively confined to younger women, seen on your left, in whom there was a 20% increase in PCR, which was statistically significant, but there was no benefit of adding carboplatin in older women with respect to PCR. These are the survival results of our study. There was an absolute increase of 6.6% in 5-year event-free survival from 64.1% in the control arm to 70.7% in the platinum arm, with a hazard ratio of 0.798 and a p-value of 0.081. When analyzed by age, there was a 12.5% absolute increase in event-free survival in patients younger than or equal to 50 years of age, with a hazard ratio of 0.642 and a p-value of 0.004. There was no benefit in EFS in patients older than 50 years. There was a statistically significant interaction between age, menopausal status, and the effect of carboplatin, as seen on this forest plot. There was no interaction with family history, stage, tumor size, or clinical nodal status. In the modified ITT population, there was an absolute 7.6% increase in overall survival from 66.8% in the control arm to 74.4% in the platinum arm, with a hazard ratio of 0.74 and a p-value of 0.029. When analyzed by age, there was an 11.2% increase in overall survival from 65.9% to 77.1% in the platinum arm, for a hazard ratio of 0.611 and a p-value of 0.003 in patients who were younger than or equal to 50 years of age, but there was no benefit in overall survival in older patients. Again, there was a statistically significant interaction between age, menopausal status, and the effect of carboplatin in terms of overall survival. Achievement of PCR was powerfully prognostic for EFS as well as for OS in the full study population, as seen here, and also in younger patients as well as in older patients. The treatment was well tolerated in both arms of the study. There was a higher proportion of patients with grade 3 or worse neutropenia, anemia, thrombocytopenia, and febrile neutropenia in the platinum arm. There was no difference between the two arms with respect to non-hematological toxicity. A high proportion of patients completed 8 weeks of taxane-based neoadjuvant chemotherapy. This was slightly higher in the control arm, 97% versus 94%. And about 80% of patients completed the full 12 cycles of planned neoadjuvant chemotherapy, again a few percentage points higher in the control arm. Importantly, treatment compliance and toxicity were not substantially different in younger and older patients. I will conclude. Addition of carboplatin to sequential taxane anthracycline neoadjuvant chemotherapy significantly improves overall survival and tends to improve event-free survival among patients with operable and locally advanced triple-negative breast cancer. The benefit seems confined to younger or premenopausal patients in whom there is substantial and significant improvement in EFS and OS. Increased PCR with carboplatin is predictive of EFS and OS benefit in younger patients, and the lack of improvement in PCR is predictive of the lack of EFS and OS benefit in older patients. The precise reasons for the interaction between age, menopausal status, and carboplatin are unclear. Our survival results are largely concordant with those of the KEPAR-62 and brightness studies, but discordant with CALGB. We used weekly carboplatin in all patients, which likely increased compliance and reduced toxicity. We used the standard chemotherapy backbone of taxane, anthracycline, and cyclophosphamide. We did not use either bevacizumab or a PARP inhibitor. Addition of carboplatin to taxane anthracycline neoadjuvant chemotherapy should be the standard treatment in patients with triple-negative breast cancer who are younger than or equal to 50 years of age or who are premenopausal. I would like to especially acknowledge the incredible women who participated in this study and their families. The numbers in my survival curves are not mere numbers, they are the life trajectories of these women. I would also like to acknowledge clinical trial fellows, data entry operators, research staff, and the other institutions that are listed on this slide. Thank you very much for your attention.
Thank you, Dr. Gupta. We have some questions online, and while people are going to the microphone, number 2, please.
Andrew London. Sudeep, congratulations on a fantastic trial. Could I ask, in this study, can you describe the proportion of patients who had BRCA1 or 2 mutations, and whether you intend, if you haven't already, to look at BRCA1 methylation and its interaction with the platinum effect?
That's a good question and a very obvious question. Less than about 50 patients in the study had their germline status determined. The study started in 2010 when this was not routinely available. We have some tissue that is available. We have performed a gene expression profiling analysis using the N-counter assay, and we hope to present that analysis in the coming year. But to your question, we do not have the germline BRCA mutation status on the large majority of patients in this study.
Microphone number 3, please.
Oprugo at UCSF. Congratulations. What a fabulous study, and really excellent to see your long efforts come to fruition and to help our patients. I was curious, and you mentioned you have done gene expression analysis. It would be so interesting to look at the over 50 population to understand whether or not there's more luminal B or normal-like histology, because there's already differences between racial and ethnic groups in triple-negative disease that may correspond to differential chemotherapy sensitivity.
Your point is well taken. It is possible that there are differences, biological differences in the tumors in older patients. Age is likely a surrogate for a biological feature. The way we have performed our gene expression analysis is to construct a case control design, and cases are individuals who had a pathological complete response. Controls are individuals who had substantial residual disease post-neoadjuvant chemotherapy, and we have representation from both the younger and older age groups in that data set. So we hope to be able to provide at least a few leads in the coming time. Thank you for your question.
We have many more questions, but unfortunately, we'll run out of time. Thank you very much, Dr. Gupta.